Wellington, and that my river is the Waipatu stream. It's not really a river, which is in the Hutt Valley of Wellington. That my peoples came across the great oceans to Aotearoa from Finland and Scotland and England. So that's our tradition back home, is to talk about where our own ancestors come from and where our place is. Okay, so my talk will be a little bit different to what you normally expect. So a couple of times I might challenge you, I might say things that are heretical for our profession, but I hope not. Down here, is it? There we go. So my philosophical position is where I'm going to start from. So I am a Christian, I'm a population paediatrician, I consider myself a progressive socialist, but I didn't put it on here, I deleted it, was the fact that I actually can work with neoliberals and had to for quite a long time. I seek to advance the rights of children, I seek to address and break the cycles of injustice, and that's partly what I'm going to talk to you about today. I hold a critical realist philosophy of science, which is at difference to many of my colleagues at work. I'm a pluralist in terms of methodology, hence I do reject controlled trials as the only truth, and I tend to more often use realist inference best explanation as the way I develop policy and practice. So I've already committed quite a few heresies, haven't I? So what are we going to talk about? We're going to talk about inequities, and a very simple slide, isn't it? That equality is not equity, and that little lad there, he's not able to see over the fence, but given a big enough box, he can see over the fence. So equality doesn't mean justice. And I'm not going to give you a lot of slides that you've seen a lot probably in the last couple of months from Professor Marmots, but just to set the scene, health and social problems are worse in countries that have unequal distribution of wealth. And that in Australia those inequities start early with smoking during pregnancy and low birth weight. So I'm going to leave it kind of there, all right? So we could have a whole talk about that, and that's not what we're going to talk about today. And there's many frameworks that people use for social determinants of health, and these two are well known to you all, I'm sure. John Lynch's one and Dahlgren Whitehead's one. Yes, and we may refer to these as we progress in this talk. And also, of course, we're all familiar with the WHO Commission on Social Determinants of Health. And we may, in this presentation, talk quite a bit about the early years in the life course. And note, and I actually don't like this diagram because it actually all starts before pregnancy, doesn't it? It starts in the previous generation and the generation before that and the generation before that, and we mustn't forget history. That's particularly important for the Indigenous peoples of Aotearoa, New Zealand and Australia. So this is from one of the Commission on Social Determinants of Health's, and it just shows the complexity of how structural determinants and social determinants are thought to impact on health and well-being outcomes. But what are the underlying mechanisms? A lot of our research is empirical in nature, so we're drawing regularities between something we observe over here and something we observe over there, but we don't really ever get to the grips of what's actually, which way is that arrow actually going. And I mean, again, I could commit other heresy here, but I won't. Maybe sometimes the arrow is actually going the other way to the one that we actually think it's going. So for example, when I did my PhD, one of my colleagues said, John, is it actually social isolation that causes maternal depression, or is it maternal depression that isolates her from the community? So which way is the arrow actually going? And in the social determinants of health, we need to, be critical. Critical realism is meant to be a bit critical. That's not what it only means. And actually try and challenge some of the things we keep saying to ourselves. So look, ecological theories are pretty common in my field. This is a famous one in developmental paediatrics, and many of you here will know of Brofenbrenner's work. And again, notice there at the bottom of often this ecological theory is not drawn like this, it's just drawn as a circle, right? but you'll notice that there's actually time, which is the socio-historical conditions and life events prior. And then there's also the epigenetic theories that are very common and prominent at the moment. Just to, this is from a discovery in Aotearoa, New Zealand, from the Dunedin longitudinal study with the warrior gene. So children are exposed to abuse during their childhood, violent, harsh parenting. If they've got a particular allele on this gene, they themselves may grow up to have aggressive behaviours themselves as adults, or to have ADHD or oppositional defiant disorder, and those sort of technical medical terms that we use for problem behaviours. If you have the other allele on this gene, you actually are resilient to that. And so there is biological mechanisms being discovered for the interaction between environment and outcome, and genes and outcomes. But I'm going to talk to you today about explanatory science, which I said at the beginning, as a critical realist. Not everything that we see is what there is. So as a tree falls down in the forest, you saw one tree fall down, but in fact, in reality, there were 100 trees fell down. You don't know why those trees fell down. Was there a giant that walked through the forest and pushed them down, or was there some aliens who came, or was there some fungi in the roots, or was there a tornado during the night? Maybe if you saw some large footprints, you might infer that there was a large person had pushed them down. Maybe if you saw some white stuff in the roots, you might infer that there was some fungus in the roots. And of course, as medical doctors, this is what we do when we do our differential diagnosis. We bring together all the evidence and do a little bit of a Sherlock Holmes thing about what is the real situation. So underline is the real situation. And so you see, I move a bit beyond the empirical. And their ontology, or their way of looking at the world as a critical realist, is that reality is not only this empirical and this hidden, but it's also layered from the biological through to the self, through to the social, through to the economic and global and big media and all of those. And we'll have a quick look at that. So Maguire put these two ontological domains of critical realism together here, and you can see that the empirical observation up there of illness, biology, things that, you know, when the doctor lays their hand on the abdomen, they feel something, so that's empirical, through to the actual, which is what's really going on, hidden in a way, through to the real, which is what are the actual underlying mechanisms for what we're observing, which in the case of that epigenetic example is to do with an allele and an interaction with violent parenting. None of which might have been immediately obvious during the clinical consultation. If we move through from the self and then onto the societal, we talk about the social determinants of health. We talk about poverty. We draw the conclusion that what we are seeing is a result of poverty. We don't actually always understand why these things are happening. And there was actually a realist paper as part of the Social Determinants of Health Commission. haven't got time today to talk about their findings. But just to draw your attention to this bottom corner here, that the underlying mechanisms are cultural. They're social, they're political. They actually came to Australia and Aotearoa from our forefathers. We brought those ideas with us. They are part of the way our society is structured, and we can understand these forces, these structures, and how they actually operate. I'm a bit of an amateur at this, so and just to very briefly move on to critical realist causal inference, which you'll see a bit of later on, and some of you in the room may have heard of realist evaluation, where this is important. So as empiricists, we have a cause and an effect, but we don't necessarily think about why that regularity exists. Realist thinking is actually looking for what are the structural causal powers in society that are triggering an event, and then what are the other conditions that are influencing that event. So in our Sydney research, I hope you can see that better than I can. Sydney is a city divided. So this is very graphically illustrates it, doesn't it? So I was recruited to Australia and crossed the mighty Tasman to work in a place called Liverpool. And Liverpool is out here somewhere, at the head of the Georges River. And in my interview, I said it's probably something a bit like South Auckland. And in fact, it was, but I didn't know a lot else about it. But now, having lived there for 13 years, I can see this is definitely a city divided between the rich in the north and the east and the poor in the south and the west. So I don't work out there any longer. I've moved into central Sydney, but central Sydney has a... So what we set about doing as child and family specialists, population specialists, is to look at the determinants in our local communities and the outcomes in our local communities. And we've been producing a series of these. There's been about 3 or 4 of these that we've produced. And for my PhD, I looked at maternal depression in the southwest, which is there. We'll have a look at that in a minute. I was very fortunate last year to have a young registrar who looked at vulnerable family hotspots in central Sydney. We were playing around with some ideas around cluster analysis. I won't bore you with the details, but you can probably see a couple of red spots here, and we'll come on and talk about those later when I start to introduce our community nests. One of these is CIFA, which most of you are familiar with, and the other one was a scale that we developed ourselves from some work that an earlier registrar had done on conduct disorder and the determinants of that. So our research has been this idea of realist theory building, and it was a realist multi-level mixed method approach. We used Bayesian spatial. This is Bayesian's a fancy mathematical technique for predicting things from data. The software we're using allows us to do maps and individual at the same time, so we can actually do a multi-level sort of study. We started off by looking at where maternal depression was occurring in our district. Now, why maternal depression? I forgot to mention that. So in the developmental origins of health and disease for children, maternal stress during pregnancy plays a very important part, and it's probably mediated not only through attachment and breastfeeding and parental responsiveness to her infant cues, but possibly also through some biological mechanisms with the adrenal pituitary axis, cortisol levels and things like that. So the Edinburgh Depression Score, which we use, is not a measure of depression, it's a measure of stress. Right? It's measuring symptomatology. It's not a diagnosis of depression, it's actually anxiety and depression together, and it's a measure of stress. So we were able to look at ecological studies of neighbourhood diversity, ethnic diversity, social cohesion, and its correlation with maternal stress. We were able to do some individual level stuff, looking at a whole range of variables that we had available to us at the individual mother's level around her social exclusion, her responsiveness, the response of her infant, and again that's an example of which way is the arrow going. Is the infant difficult behaviour because she's not responding to its cues, or is it the infant temperament that is somehow influencing mum's anxiety and depressive symptomatology, or is it both? And we've only got an hour, so I won't go into more detail on that one. So we then were able to do some studies, multi-level spatial studies, and some qualitative work, both at the individual level and group level, and suggested that, in fact, social capital, which is very supportive of mothers at an individual level, that is how many, what her social network's like, how many friends she's got to call on, acquaintances, neighbours that she's got to call on for both material and information resources, etc., actually was detrimental at a multi-level, at an ecological level for migrant mothers. So migrant mothers living in a community that had strong social capital were probably being socially excluded. So their rates of depressive symptoms was higher than when they were in a community with strong social capital. What a paradox that was. And it actually was able to find that this had actually been found in other studies in the United States, so it wasn't just an isolated study, and we won't dwell on it too much because it needs to be replicated and confirmed. So one of the qualitative approaches we took was, and this is in press at the moment, is situational analysis, which is a form of grounded theory. And I want to talk a little bit about this, if only I could see what's on my screen in front of me, because this is really, in this diagrammatic way, capturing quite a number of themes that came from our qualitative focus groups and interviews, and it sought to explain some of what we'd picked up through our regression studies and our multi-level studies. So you can see here that this is representing the household, the home with the baby, and usually a mother, and she's trapped in this household. Her expectations have been shattered. Motherhood is not at all like is shown in the glossy brochures or in the glittery media or what's on show down at Westfields. She is socially isolated. She can no longer connect with her school friends, etc. She's got this loss of control of this infant, and loss of expectations. And I could go on. In those communities, the houses are cold, something I didn't expect when I migrated to Australia, that it could be so cold in Campbelltown, and then hot at the other time of the year, and she can't protect herself or her family from these extremes of temperature, and there's mold in the houses, etc. And the community around her is decayed. It's not safe. There's roaming gangs, there's drugs, there's needles. I found this when I stayed in the nurses' home in Liverpool, that there was somebody shooting up in my shed, and that all around that area there were syringes on the ground. So this is a picture of isolation, urban decay. You can't play in the parks because it's not safe, and she can't get to Westfields because there's poor public transport. And I could go on. And you can see in this diagrammatic picture that in fact there are other areas where it's not like that, where in fact there are lakes and trees and parks, and it's safe to have playgroups in the park and etc. So you'll see that these circles, these social arenas have been drawn. So we've got this idea here of the social cohesion arena. We've got this idea of the economy playing a role, of big business playing a role, and of national policy and that all playing a role. And to quote one of the mothers, she said, everything's in our lives anyway. So, and that fitted with the situational analysis author, Clark, where it's not an onion with all these layers going out and out like this, but it's actually, everything comes right into the immediacy of your life. So if there's a policy change today in Canberra, it affects her today as well, or tomorrow. Even just voice, even if a minister says something on the media, it immediately affects her and how she's feeling. And I think that's what's happening, unfortunately, for our Muslim community at the moment. So putting this all together, we construct some sort of theory, and that's all it is. It's just a theory. But if you look at it, and I don't want you to read the word stood, it is actually in these layers. So we've got the outer layer of the, what have I wrote there, global economical mechanisms that are at play, powerful forces at play globally. Something's in the newspaper this morning from the UK about their new Prime Minister and what she's saying, and that is immediately impacting on us down here under. And then there's the local neighbourhood context, which I tried to describe to you, and there were elements of that we missed. And then right into the household itself, into the psychological mechanisms and the interactions that are going on between the various family members, and then further down into how that's affecting her, the mother, her feelings, her anxiety, her depression, and her hormones. Not her female hormones, but her other hormones, the cortisol and etc., and oxytocin. So then how do we go about doing something about this? How do we confirm this theory? How do we intervene in all of this? And so this idea of taking our theory through to intervention. So this is from a manuscript I'm writing at the moment, but the idea is here to actually try and validate this theory either by repeating those studies again or by taking those theories into some sort of intervention into those mechanisms and then seeing whether it will work. Now we can do that through a randomised controlled trial, and they have a lot of areas we can do that. So I'm not opposed to randomised controlled trials. In fact, there are realist randomised controlled trials now available to us. But the idea is to take this theory, and this middle range theory they call it, and translate it into a program theory. But this is a diagram that I quite like, and that's this idea that we've got this, when you do logic models for program intervention, you know, you have, oh, we're going to do this activity and it's going to result in this outcome. You very seldom actually think about how is this activity going to result in that outcome. So this is this idea that the activity you're going to do is going to actually alter the way somebody thinks or the way somebody behaves, or around collective beliefs or their preferences. Realists talk a lot about tendencies. So a tendency for people to do this as opposed to this. So when we're running parenting programs, we need to think about how is that actually working? Because if we can understand how it's operating here, we can figure out why it doesn't work. Or we can figure out maybe why it does work and do more of it. A colleague of mine from Toronto had done what's called a realist emphasis, where she takes a whole bunch of studies that have been done and looks for the underlying mechanisms that are reported in the literature. And we like her work. We think this resonates with us, and we've tried to use it in our design and in our intervention. And that is this mechanism of willingness to share status and power between clinicians themselves, between clinicians and their clients that they're working with, between managers, between policy and people of different levels, willingness to share status and power. Trust, not only between provider and client, but trust between providers. Provider confidence to actually deliver the program, or confidence in the other providers. I'm adding a little bit to this because it's based on our current evaluation. And then finally, self-reliance, building self-reliance of families who have been traumatised, been marginalised, etc. So we went about to try and design something in central Sydney. We were lucky because we had good sponsorship, but it was to be a collaborative design. We wanted to develop a shared agenda across all the agencies, government and non-government and community. We wanted to develop some mutually reinforcing activities. That means not just one activity randomly over here and another one over here, but activities that actually will work together. And hopefully I can briefly illustrate that. Communication and a backbone organisation. It's when you're be humble and say, are you the backbone organisation or somebody else the backbone organisation? I think in our district there are two backbone organisations, and they're working very well together. One is Family and Community Services and the other one is Health. So we went about, and this took quite a long period of time, so we ran a vulnerable family. We did some, you've seen this before. This is our study of the inequities within our district. We then did some consultation, ran some forums, developed a Inner West Vulnerable Family Kids and Families Forum report, wrote a business case. The business case initially, that was 2013. Now the business case drew on scientific evidence as well. So those of you who work in my field or know something about this field will know that sustained nurse home visiting has been subject to various randomised controlled trials. I won't say that the evidence is strong as some people say it is. There is actually jury out. I think UK has just decided to pull the plug on family nurse partnership for for the spurious reasons I would suggest, but anyway. Those of you who are in that camp will say, yes, sustained nurse home visiting is something that you should do. That allows you to reach all the vulnerable mums, because we do it by identifying mums antenatally, across the whole of our district. At the time, we didn't have enough money to do that, so we decided we would do it in 2 communities. And the other approach we wanted to take was an integrated service model. Now, there is some evidence on the US. If you look at the Aracy report on the early years that they did on contract to the New South Wales government, you'll find some of the review of the literature there around that. And of course, to support all of this, we needed to actually make sure that we had fidelity of these and that we could monitor and support these scientifically. This wasn't funded initially, but subsequently, the New South Wales government decided it would invest heavily in integrated care. So we put up an expression of interest for that for about 5 million, and we're successful. It's called Healthy Homes and Neighbourhood Integrated Care Initiative. At the same time, though, we had actually been working on those shared values, those shared goals, etc. And so we wrote that into the Healthy Homes and Neighbourhoods as component 7, about getting shared outcomes, partnership, shared agreement on change, system change. And that eventually became the Child Health and Wellbeing Plan, which is one of the first interagency plans in New South Wales. That's not a child health plan, so it doesn't look at what the health department's going to do about breastfeeding or about early discharge or whatever. It's an interagency plan, and it has 4 major partners. It's got the health district itself, it's got family and community services, it's got the primary health network, and it's got this other organisation that we belong to, which is called the Collaborative Practice Management Group, which is actually a daughter of the New South Wales Families First, Families New South Wales initiatives that some of you will know about from starting from 2000 moving forward. But that organisation has representatives from all our NGOs and ourselves, of course, and local government and schools as communities initiatives. So the design of our initiative is quite complex, but essentially they're all mutually supporting. So we've got a care coordination trial going on across the district, which is to identify vulnerable families and ensure that we can wrap services around them. We've got what we want to do for sustainability is link our families to GPs and support our GPs to work with our families. We've got 2 place-based initiatives, one in South Sydney, one in Canterbury, and a whole range of capability projects which I'll be able to touch on very briefly. And then health literacy using family health improvement approaches. There was a theory of change underpinning this. I won't be able to read it all to you here, but it's about our families who are disconnected from our service system, who are marginalised, and they have chronic health conditions, mental health conditions. They've got multiple services coming in and out of their lives but not staying there. And we wanted to move forward with some family-focused, joined-up initiatives. One of those initiatives that I wanted to talk about today was community nests. We didn't go home to New Zealand at Christmas for a variety of reasons, and I found myself in the social housing towers between Christmas and New Year with pouring rain outside, locked in a room with housing colleagues. And we'd had a hard 6 months with some very tragic clients and their experiences of the system. Yes, 75% of them Aboriginal mums who had been homeless, found sleeping in the park at 36 weeks pregnant, etc., etc., etc. And how we had worked together with housing to find appropriate accommodation and wrap services around them. So there are this idea of having these community nests, and you've seen this slide before. We've decided we're working on a nest here and another one out here in Riverwood. Riverwood's an interesting case It's not evident from this map, but it's actually on a boundary between 3 health districts and is completely marginalised from services, and no one can actually agree who's actually servicing that housing estate. So in fact, they don't get mental health services from our district. They're supposed to get it from the other district, but I won't go on, all right? And they get their drug health services from a 3rd district. So it's marginalised, it's neglected. These are our core partners. You won't know many of them because you're from down here, but we've got a Sydney Day, SDN, the Sydney Day Nursery Children's Services, who provide an early intervention program called Brighter Futures. Bernardo's and Benevolent Society you've probably heard of, or may even have them here as well. Janawi is a child protection family centre right in the heart of Lakemba in Canterbury. And educational, juvenile justice and local government, etc. And now there are many other partners as well. Co-location is a critical mechanism. I use that word mechanism deliberately because when you get into realist evaluation, that's actually what it's about, is changing structures, changing practice, changing protocols, changing the way you actually do things. Co-location, I think I'm going to be saying, is the critical thing that actually got us all working together. Sitting around a table, having a yarn or chat, and then nothing changing, but actually co-locating, sitting in that office together in the basement of the social housing estate where there had been some high-profile murders just 2 years ago, engaging directly with local services, local community, identifying needs, not having an agenda, not having a plan, but actually allowing the plan to evolve as we work with the community, together with some school projects that we were dealing with there. Critical to this particular model was not only co-location but wraparound, that is intensive wrapping of services around our clients as we identify them. We're not working on paediatric issues, we're working on parent issues. So most of our work and the staff that we recruited are working with adult chronic disease, adult mental health, adult drug and alcohol problems, adult legal issues, because we've got a justice health partnership, adult income support issues, and helping them to find employment. Yes, we had some high-profile folk come and visit us there, and we've got an initiative going on at the local preschool, which is where a lot of the local families are going, and this has been extremely good initiative, the preschool initiative on that estate. We're able to link these families to GPs and link them to legal advice, immigration advice, parenting groups, toy libraries, etc., and get their teeth painted. The Canterbury Nest but we started there and we're now starting in Canterbury, so this one's behind the other project. But we've doing local needs analysis, local community consultation, and trying to find a place where we can co-locate services. And it may not be housing this time. It looks like it's going to be a local education district office. We've got tools that we use. I think Patchwork's actually been trialled here in Melbourne as well. I think there's even a My Patchwork which has been developed. This is a tool from the UK which allows us, it's a virtual web-based super directory of who's working with a client. And we're developing our own family practitioner knowledge school processed e-learning modules for GPs, health literacy website, and this we hope in time will be available through local kiosks for people, because I mean they don't have access to phones. We are trying to build Wi-Fi hotspots. They do have phones, but they're the old type, Nokia type. So we're not naive about all of this. We are doing research with our clients about how they want to receive health literacy information, etc. But nevertheless, we're thinking forward, and there are various phone apps being developed. So finally, if I move on to how we're evaluating this. So we're using realist evaluation approaches. There's a difference between scientific realism and critical realism, so if you're into that, we can talk later. We're trying to use a critical realist, or trying to understand the difference between the two is hard enough. And just to say that in the realist evaluation, you describe the context, the conditions, the structural situation that you're moving your program into. So this was a high crime area. There was a murder in the apartment right next to where our hub is, the apartment next to it. When I first went there, that was a completely trashed area, there were needles and syringes everywhere, and there was street drinking, and families were scared and isolated and didn't know where to go for help. And even though the agents, it was said to be one of the highest serviced areas, in fact, the families were not getting the services. There were barriers, a lot of trust issues with us. Our Indigenous families don't trust us and don't trust anything with the New South Wales Waratah on it, hence our own logo. So we've got some qualitative research been happening with our clients, and that's another story in itself, is how to do that. So this is from 7 client interviews and some practitioner interviews. So it's ongoing work. And what's coming through is that they're feeling less socially isolated. They're more likely now to venture out of their houses. There's increased pride in their community. All the community rooms in the social housing estate are now being used for activities by NGO partners and justice partners, legal aid partners. They come to the central point for help, and that is, I can't overstate that. I mean, they can just drop in there, and the usual story is a grandmother dropping in tears to say that her 15-year-old daughter or granddaughter is pregnant again, and she's had 2 previous children removed. So these are the stories that we're having. And the families literally across the road that were not accessing services and not known to services, and it's this sort of... So the agencies themselves are now trusting each other. There was a lot of standoffishness from certain agencies. They're now actually in there. I went to the steering committee last week. It was absolutely amazing, the dynamism that's actually coming across from the legal sector, the local government, City of Sydney sector, from NGOs that work with youth to chronic care. District nursing services are working with hoarders in their apartments and etc. There's a knowledge transfer happening where we work in our silos. We don't use the same language. I think there was about half an hour of that meeting was actually discussing a particular term, because our legal colleagues and our facts colleagues and us all use that term in a different way to try and get a shared language around some of these things that we're talking about, or shared assessment tools. So when someone drops in, there's a common set of questions that are asked. A greater understanding of what is a paediatrician, or what is, why are there 5 legal advice? Did I exaggerate? Maybe not. So one does tenancy, one does something else, one does family, one does, and so I didn't realise there are all these different legal advisory, and they're NGOs and they don't charge their clients. So I didn't know that. So actually understanding each other's roles and their limitations. You can't ask the tenancy legal folk a question about unpaid fines, for example. That's another folk. Just like you can't ask a paediatrician to look at mum's perineum. And that, by the way, that was a real issue for us, because these mums were losing their kids, and when they lose their kids, they lose their services. So they never got any postnatal checks. So that was something we had to figure out. Holistic approach, whole person, nothing is off the agenda, whole family, we're wrapping services around the family, connecting care. The care coordinators are seen as being personable, having good rapport. One of the underlying mechanisms is going to have to be around relationships and trust. And the client's now feeling that they're important, that they're feeling more empowered. We're using a range of tools, which I haven't got time to talk to you about today, around measuring growth and empowerment type tools. That will be part of the quantitative evaluation, which is got its own struggles. So what are we doing? We're working collaboratively. We can reduce the impact of these negative social forces on children and families. I'm not for a minute denying that we need an increase in income support. And it was interesting to see a business blog recently about what's happening in Finland, that in fact giving money to families may be more powerful than early childhood education. That's an interesting discussion to have. So I'm not denying that, but in our local patch, what can we do to reduce the impact of these negative social forces or to enhance the positive impact of some of the policies? Because the problem we were facing was that there was no in-reach of our services, very limited in-reach of these policies into the lives of our families, and trying to understand why a family was not accessing benefits that they're entitled to. So we might have all this macro policy, but in the lives of our clients, they don't know that they're entitled to this. They don't know that they're entitled to have their state debt written off if they just turn up to a parenting group. So those are interesting. So again, coming back to this idea that we're locally addressing in the social arena what's these words. And these words on this picture come from the voices of mothers. So they're in the richness of the text from the qualitative research, that there are transport problems. Who would believe that living in Redfern, central Sydney, you don't have public transport to the Royal Prince Alfred Hospital or to St Vincent's or to the Prince of Wales? You don't. And I only found that out myself because I had a visitor from New Zealand who was a school teacher who wanted to go to the local secondary school in Redfern and then from there go over to Marrickville. And to do that, he had to catch the bus into the Central Circular Quay, walk a kilometre to another bus stop to catch the bus back out to Marrickville because there's a huge rail corridor goes through there, which means there's no cross-city transport. So public transport, and I won't talk about Riverwood, there's no public transport out there. So that's why we're trying to do outreach. And to get drug health and mental health and child health actually outreaching into those communities is what we're proposing to do there. I'm actually at the end, Brett. So again, I come back to let's look at what those underlying mechanisms are and address those. Trust, power, confidence and self-efficacy. And from there we can work towards a brighter future. Thank you.